Hi, my name is Dr. Barranco Travi, and I am an intern in the internal medicine program at Tripler Army Medical Center. And I have the great opportunity to present to you a rare case of Streptococcus sanguinis associated with brain abscess, bacteremia, and infective endocarditis. A case done in collaboration with Dr. Mank, Dr. Brown, Dr. Kisling, from the Department of Internal Medicine, under the supervision of Dr. Shai from the Department of Infectious Disease at Tripler Army Medical Center. The learning objective of our case report is to create awareness and to report that Streptococcus sanguinis by hematogenous dissemination can present as a triad of bacteremia, endocarditis, and brain abscess, and to compare Streptococcus sanguinis triad to Ostrom syndrome, which is another triad. This case report is of a 62-year-old Korean veteran that was brought into the emergency department because he became somnolent. His wife, the historian, stated that the patient over the last week have been having high fever and complaining of severe headaches. Patient wife state he is a heavy drinker who enjoyed binge drinking vodka and smoking marijuana. On presentation, patient is lethargic but able to communicate symptoms of headache. On past medical history significant of alcohol use disorder with hepatic steatosis. Past surgical history, patient had an appendectomy done. Social history, he has a 20-year pack of cigarette smoking, heavy vodka drinker, as described previously, and smoke marijuana recreationally with friends. He lives with his wife and is able to perform his activity of daily living. On baseline, he is alert and oriented to time, person, and place. Family history is unknown. Medication denies taking any medication on regular basis. Allergies to penicillin. Review system unable to obtain due to patient mental status. Vital signs on presentation, he has a systolic blood pressure of 143 and a diastolic of 91, heart rate of 68, respiratory rate of 16, temperature of 98.2, and satting at 99 on room air. Physical exam, patient was somnolent with positive nuchal rigidity. Neural exam, limited due to mental status. Laboratory evaluation showed an elevated white blood cell count of 19, lactate of 1.4, procalcitonin of 0.42, and he was COVID and HIV negative. The picture on the left is a non-contrast head CT. It shows a vasogenic edema involving the left frontal lobe and insula. Findings concerning for malignancy. Given patient elevated white blood cell count, an infection process may also be considered. Therefore, we obtain a brain MRI for further evaluation, which is the picture in the middle. The brain MRI demonstrated a 2.5 times 1.7 times 3.7 centimeter mass in the left frontal lobe with peripheral enhancement, which consisted with abscess. Transthoracic echocardiogram revealed a mitral valve regurgitation with a posterior mitral valve leaflet vegetation. Empiric treatment was initiated with piperacillin and tazobactam, and soon after transition to vancomycin, metronidazole, and ceftriaxone. Following left frontal craniotomy for brain abscess drainage, the patient subsequently developed intracerebral hemorrhage and syndrome of inappropriate antidiuretic hormone secretion. Blood and brain abscess fluid culture grew Streptococcus sanguineus. Histological analysis of the brain tissue showed parenchyma abscess, granulation tissue, and gliosis. Antimicrobial therapy continued with ceftriaxone 2 gram IV every 12 hours. which led to a clinical recovery. The patient was evaluated by oral and maxillofacial surgery for a likely nidus of infection from chronic periapical dental cavities at the tip of root number 6 and 9, which was extracted. Streptococcus sanguinis is a gram-positive cocci. It is the most abundant bacterial genus in the human oral cavity that has been widely associated with the development of infective endocarditis. While the association of Streptococcus sanguinis with bacterial endocarditis is well described in the literature, we present the first case that included triad of brain abscess, bacteremia, and infective endocarditis. In our case, Streptococcus sanguinis brain abscess was likely secondary to the oral dental cavities since it's part of the normal microflora of the mouth. This microorganism is able to seed by hematogenous spread. Therefore, it is imperative to obtain an echocardiography screen by transthoracic echo due to the high prevalence of mortality of endocarditis associated to bacteremia. Once identified the microorganism based on culture, we narrowed the antimicrobial therapy to cover for it and selected an antibiotic with a good brain barrier penetration. That's the reason why we choose ceftriaxone. Streptococcus sanguinis is not the only bacteria associated with the triad. Streptococcal pneumonia infection also has a triad described as meningitis, endocarditis, and pneumonia, known as Austrian syndrome. Austrian syndrome has some risk factors that are the same in Streptococcus sanguinis, such as a history of alcohol abuse, male sex, and advanced age. Given the high degree of associated fatal complication with Streptococcus sanguinis infection, clinicians should carry a high degree of suspicion for this organism when these patterns arise.